Welcome to the deep dive. You've handed us a dense, absolutely critical chapter 49, the management of patients with urinary disorders.
It really is.
This is pretty much the bedrock of urologic nursing from your medical surgical text.
Right.
Our mission today is to cut through all that clinical density and transform this essential material into a clear, synthesized learning path.
Exactly.
We're going to hit every major concept, from the simplest UTI mechanism all the way to the complexity of urinary diversions, so you can walk away truly informed.
That's the plan. The urinary system is just so fundamental. It's the route for drainage of urine formed by the kidneys.
Of course.
And when things go wrong, whether it's an infection, an obstruction, or trauma, the nursing management demands a really comprehensive grasp of anatomy, diagnostics, and, those critical patient interventions. So we're going to use this material as our guide. We'll explore infections, dysfunctional voiding, kidney stones, trauma, cancer, and the extensive post-surgical care involved in diversions.
So this is your targeted focus for mastering this field.
That's it.
All right, so we have to start with UTIs.
We do.
They're the second most common infection overall, responsible for a huge number of hospital admissions, and frankly, they represent a massive safety and quality concern in healthcare settings.
A huge one.
So before we even talk about treatment, let's just nail down the basic plumbing and physics of how these infections even start.
Okay, so a UTI, by definition, is pathogenic microorganisms invading the urinary tract.
Right.
And what's crucial to remember is that the tract is normally sterile above the level of the urethra. So when we talk about lower UTIs, we are focusing on the bladder, that's cystitis,
Cystitis.
prostate, which is prostatitis, and the urethra, which is urethritis.
And the body has this really complex defense system in place to maintain that sterility. You can almost think of the bladder as a fortress.
That's a good way to put it.
Its defenses are multifaceted. You have the physical barrier of the urethra itself. You have the continuous flow of urine that's constantly washing things out.
A flushing mechanism.
Exactly. And then you've got that competent valve where the ureter meets the bladder, the uretrovesical junction, and the immune components like antibacterial enzymes and antibodies that are located right in the mucosal cells.
But for an infection to take hold, it requires 3 steps. The bacteria have to get 1, access the tract.
Okay.
2, they have to attach to the epithelial lining. And then 3, successfully colonize, all while evading those defenses you just described.
And most of the time, where are they coming from?
Overwhelmingly, these infections result from fecal organisms. Most often, it's E. coli, which is sent from the perineum up into the urethra.
And this leads us directly to a really crucial component of the defense that I think often gets overlooked: the glycosaminoglycan layer, the JAG layer.
Yes, the JAG layer. You can think of this as a hydrophilic sort of protective shield.
A water barrier.
A water barrier that makes it incredibly difficult for bacteria to adhere to the bladder wall.
Okay, and here's the synthesis moment for you. If this natural chemical defense is so vital, what compromises it?
That's a great question. The source material is really clear that certain common agents can impair this layer.
Such as?
It specifically mentions cyclamet, saccharin, aspartame, and tryptophan metabolites.
So we're talking about things in our diet.
Exactly. This is a critical teaching point for patients. Non-infectious dietary elements can actually undermine their natural defense, which increases their susceptibility to bacterial adherence.
That's a great example of synthesizing the why dietary restrictions might matter even for something as common as a UTI.
Right.
Now, let's talk mechanics. When those defenses fail, we often see reflux, the backflow of urine, and that's what facilitates the infection. The text outlines 2 main types, and they are functionally very, very different.
The first one, and it's the less serious of the 2, is urethrovesical reflux.
Okay.
So imagine the dynamics of pressure. This is the backward flow from the urethra back into the bladder.
And what causes that?
It happens when high pressure, like from coughing, sneezing, or even straining, forces a small amount of urine and potentially bacteria down into the urethra.
I see.
Then, when that pressure normalizes, that contaminated urine flows right back into the bladder. It's a pressure dynamic failure.
Then you have the more consequential type, which directly impacts the kidneys.
Yes, ureterovesical reflux.
Yeah.
Sometimes called vesicuretal reflux.
And this is really a valve failure, right?
It is, absolutely. The uretrovesical junction, that critical valve between the bladder and the ureters, is incompetent. It's not working properly.
Okay.
Normally, that valve closes when the bladder is full or contracting, and that prevents bacteria-laden urine from going up.
From ascending.
Right. But if it fails, That contaminated urine can flow all the way up the ureters and reach the renal pelvis, causing stasis and setting up the perfect conditions for a serious upper urinary tract infection or pyelonephritis.
And that's a much bigger concern because now we're threatening kidney
A
function.
much bigger concern.
So when we look at which patients are at high risk, we aren't just looking at hygiene, we're looking at anything that disrupts flow or compromises immunity.
That's right.
Conditions like diabetes, pregnancy, gout, neurologic disorders are all listed as contributing factors.
But the mechanical risks are huge.
Right.
Any instrumentation like catheterization or cystoscopy, or any form of obstructed flow like strictures, tumors, or kidney stones dramatically increases the likelihood of infection.
For a lower, uncomplicated UTI, the clinical signs are pretty distinct and highly memorable.
They are. We look for burning on urination known as dysuria.
Dysuria.
Frequency, which means voiding more often than every 3 hours.
Okay.
Urgency, nocturia, and that kind of localized suprapubic or pelvic pain.
And what about blood in the urine?
Hematuria and back pain can occur, but they definitely raise your suspicion for an upper tract involvement.
What's sobering is how widely these manifestations can range, from being completely asymptomatic to, developing life-threatening sepsis.
We have to emphasize urosepsis.
Yes.
That's the systemic infection that results from the spread of bacteria from the urinary tract right into the bloodstream.
So if you have a patient, especially an older adult or anyone with an indwelling catheter, who suddenly shows signs of septic shock,
You have to assume urosepsis until you can prove it's something else.
this is where we hit the safety priority. Hospital-acquired UTIs, specifically CIUTI or catheter-associated UTI, they account for half of all hospital-acquired infections.
It's a staggering number.
And we need to remember the financial and ethical weight of this. The Centers for Medicare and Medicaid Services, CMS, classified CIUTI as a never event.
Meaning they won't reimburse the hospital for treating it.
Exactly. And that places enormous pressure on nurses to practice strict prevention protocols.
It's a huge financial incentive that really drives practice change.
Let's pivot to our older patients because the incidence of bacteriuria rises dramatically with age and disability.
When we consider our geriatric patients, several things really stack the deck against them. They often experience decreased bladder muscle toning capacity, which leads to increased residual urine volume after voiding.
So the bladder isn't emptying completely?
Not completely, and you can add to that cognitive impairment, neurogenic bladder from strokes or diabetes, and a decrease in the antibacterial activity of prostatic secretions in men.
And what about for postmenopausal women?
For postmenopausal women, the lack of estrogen makes the vaginal and perineal tissues more susceptible to bacterial adherence and colonization.
Which is why sometimes you see topical or even oral estrogen replacement helping to restore that natural protective acidic pH of the vagina.
Exactly. And what's critical for your assessment is that in older adults, UTIs often present subtly.
You're not going to see the classic signs.
You might not see the classic dysuria. Instead, you might see new onset urinary incontinence, malaise, foul-smelling urine, or, most worryingly, delirium or acute confusion.
So diagnosis rests on confirmation via a urine culture.
That's the gold standard.
And the established clinical definition for significant bacteriuria is a colony count greater than 100,000 CFU per ml on a clean catch midstream or catheterized specimen.
But not every patient with symptoms needs a full culture. The source material highlights specific patient populations who always require a mandatory culture.
Why is that?
It's due to the high likelihood of underlying issues or complications.
So who's on that list?
This list includes all men, all children, pregnant women, patients with recurrent UTIs, those with diabetes, or really anyone who has recently undergone urologic instrumentation.
So for these groups, we're assuming it's complicated until proven otherwise.
That's the safe way to approach it,
Beyond culture, cellular studies are looking for pyuria.
which is the presence of white blood cells in the urine.
And while pyuria is present in all UTIs, it's a critical synthesis point that it is not specific to bacterial infection.
That's a great point. It can also be a sign of renal calculi, interstitial nephritis, or even tuberculosis.
And the quick check that you'd use on the floor is the multiple test dipstick screening for leukocyte esterase and nitrates.
Right. If we suspect structural issues or pyelonephritis, then we move to imaging.
Okay.
X-rays, CT scans, those are excellent for spotting pyelonephritis or abscesses. And ultrasonography or kidney scans are very sensitive tools for detecting obstructions, cysts, or tumors.
Acute medical management aims to rapidly eradicate the bacteria with an agent that minimizes disruption to the normal flora.
Right. For uncomplicated lower UTIs in women, the trend is towards shortened uh, 3-day antibiotic courses, though 7-day courses are still common.
And what classes of drugs are we talking about?
We use classes like nitrofurantoin, cephalosporins, fluoroquinolones, and trimethoprim sulfamethoxazole.
And for the debilitating symptoms of burning and pain.
We prescribe phenazopyridine, which is a urinary analgesic.
And you have to warn patients about the side effect with that one.
Absolutely. You have to tell them this medication turns your urine a very distinct orange-red color so they don't get alarmed.
And for the 20% of patients who experience recurrent infections, long-term management is necessary.
Yes, if the infection returns quickly, a relapse within 2 weeks. The infection source is likely the upper tract or the prostate.
So that requires a longer course of treatment.
A much longer secondary course of antibiotics, followed by a regular prophylactic dose, which is often taken at bedtime.
Let's touch on complementary therapies because the text acknowledges the use of cranberry.
It does. A meta-analysis shows that daily cranberry intake, particularly in capsule form, can significantly reduce the rate of recurrent UTIs compared to a placebo.
But how does it stack up against antibiotics for treating a recurrence?
Well, when you weigh them against each other, the antibiotics are ultimately more effective, despite carrying the greater risk of severe side effects like Stevens-Johnson syndrome.
Okay, so now let's integrate the nursing process. In assessment, the history is paramount. You need specific details on voiding patterns, pain, urgency, the relationship between symptoms and intercourse. We also need to assess urine quality, the volume, color, odor, and cloudiness.
And the nurse is also uniquely positioned to assess the use of complementary and alternative medicine, or CAMAM therapies.
Right, which is vital for conditions like interstitial cystitis, where behavioral modifications and dietary changes are often the primary treatments.
Our core nursing diagnoses here are pretty straightforward. Acute pain and lack of knowledge related to prevention.
But our collaborative focus must be on preventing those serious complications.
Namely urosepsis and the potential for acute or chronic kidney injury.
Interventions start with pain relief and flow management. We encourage liberal fluid intake.
Water and cranberry juice are the best choices.
And strict avoidance of bladder irritants. So that's coffee, tea, alcohol, citrus, colas, and spices.
And regular, frequent voiding, ideally every 2 to 3 hours, is essential to keep those bacterial counts low and prevent stasis.
Antispasmodic agents, prescribed analgesics, and applying heat to the perineum are also important pain management tools.
Monitoring complications requires constant vigilance. We have to educate the patient to report signs of progression immediately.
So things like fever, fatigue, nausea.
Nausea, vomiting, or pruritus. And again, the CAUTI prevention priority is non-negotiable in the hospital.
Right.
Given the high mortality rate of gram-negative sepsis, anywhere from 25 to 60%, immediate, aggressive treatment IV fluids and IV antibiotics must be initiated quickly, especially in vulnerable patients.
The ultimate goal is prevention through patient education. Key points we have to teach are non-negotiable.
Such as?
Showering instead of bathing, correct front-to-back perineal cleansing, maintaining that liberal fluid intake while avoiding irritants, voiding every 2 to 3 hours and ensuring the bladder is completely emptied, and specifically for women, voiding immediately after penile vaginal intercourse.
And they have to finish every single prescribed medication.
Reward.
So we shift our focus now to the upper tract. Infections here are less common, but they're inherently more dangerous because they involve the renal parenchyma. This is pyelonephritis, which, as we discussed, is a frequent cause of urosepsis.
Pathophysiologically, this is a deep, severe bacterial infection affecting the renal pelvis, the tubules, and the interstitial tissue.
And it's usually ascending from the lower tract.
Right, so any form of obstruction or an incompetent uretrovesical valve dramatically raises that susceptibility.
And when this occurs, the kidney becomes enlarged, infiltrated with inflammatory cells, and you can even see abscesses forming.
The clinical distinction from cystitis is really the presence of systemic symptoms.
Exactly. You're thinking high-grade infection, chills, high fever, elevated white blood cells or leukocytosis, bacteriuria, and pyuria.
Plus, you have the localized symptoms of low back and flank pain, often accompanied by nausea, vomiting, and general malaise.
And the defining physical finding you must assess for is pain and tenderness when you palpate the costovertebral angle, or CVA.
And the management differs significantly from a simple UTI.
It does. If the patient is clinically stable, outpatient treatment is possible.
But the antibiotic course is much longer.
Typically 2 weeks or longer because the infection is deep within the renal tissue, which makes it much harder to eradicate.
And hydration is crucial.
Crucial. Oral or parenteral fluids aiming for 3 to 4 liters per day if the patient's cardiac status allows it to really flush the system.
And a non-negotiable safety check. A follow-up urine culture 2 weeks after completing treatment is mandatory to confirm total clearance.
Chronic pyelonephritis results from repeated scarring bouts of the acute infection.
So the kidneys become contracted, scarred, and they lose function.
It's a quiet, insidious condition, but it has severe consequences. It is, in fact, a major cause of chronic kidney disease, or CKD, that eventually requires renal replacement therapy, like dialysis.
The manifestations are often nonspecific or even completely absent until a late-stage flare-up.
Right. When symptoms do appear, they're vague. Chronic fatigue, a persistent headache, poor appetite, polyuria, which is excessive urination.
Excessive thirst and weight loss.
The list of complications is severe. End-stage kidney disease, hypertension resulting from the renal damage, and the formation of renal calculi, especially if the infection involved urea-splitting organisms.
And medical management is focused on prophylaxis.
Right. Long-term antimicrobial therapy to limit future recurrence and carefully monitoring kidney function, which will dictate how you dose the drugs.
Nursing management for these hospitalized patients demands meticulous attention to detail.
We have to measure and record IO religiously.
Right.
We have to ensure that high fluid intake, 3 to 4 liters daily, is maintained and monitor their temperature every 4 hours.
And crucially, patient education focuses on 2 things: maintaining that high fluid intake and strict adherence to the full antimicrobial regimen to prevent any further scarring.
Okay, now we move away from infection to issues of function.
Right.
Specifically, the ability to appropriately fill and empty the bladder, a process we call maturation.
And failure in this area, if it's chronic, can compromise the entire upper urinary system.
Urinary incontinence, the involuntary loss of urine, affects over 25 million adults, impacting women twice as often as men.
And we need to be really clear with our patients. While it's common in older populations, it is not a normal part of aging.
Right. Patients frequently hide it due to embarrassment, which means it is vastly underreported and undertreated.
The list of risk factors is extensive.
It is. Advanced age, cognitive disturbances like dementia or Parkinson's, class 3 obesity, diabetes, and pelvic muscle weakness caused by pregnancy or delivery.
And medications can play a major role, too.
A huge role. Things like diuretics, sedatives, or alpha-adrenergic agents.
When we assess the older patient, we have to consider age-related changes, decreased bladder muscle tone, reduced capacity, and increased residual urine.
But we also have to look for transient incontinence.
This is crucial for nurses. Transient UI is often acute in onset, and it's reversible if we address the underlying cause.
So what are some of those reversible causes?
Common ones are an acute UTI, severe constipation, delirium, high fluid intake late in the day, high blood glucose levels, or a new medication regimen.
Let's synthesize the 6 types of incontinence because they really dictate the treatment path.
Okay, number 1.
Stress incontinence. This is loss of urine with increased abdominal pressure, sneezing, coughing, exertion.
And the critical insight here is that the urethra itself is intact, but the supportive pelvic floor has failed.
Exactly. Common post-delivery in women or post-radical prostatectomy in men.
Number 2.
Urge incontinence. This is defined by a sudden, strong, uncontrollable urge. The bladder muscle, the detrusor, contracts involuntarily, giving the patient virtually no time to reach the toilet.
Okay, 3rd is functional incontinence.
Right, where the lower tract is fine, but the cation is impaired. Immobility, dementia, or severe arthritis prevents them from accessing the toilet in time.
Then you have iatrogenic incontinence,
which is caused by external medical factors, most often medication side effects, like alpha-adrenergic agents causing the bladder neck to relax. This type resolves when the medication is stopped.
And then there's mixed incontinence.
Simply put, that's leakage associated with both the urgency and the exertion or stress.
And finally, overflow incontinence.
That's a continual leakage from a bladder that is severely overdistended. The bladder is full, but it cannot empty, usually due to an outlet obstruction like BPH or a flaccid bladder muscle.
So management always starts with the least invasive approach.
And that means behavioral therapy. This is the first-line treatment for non-neurologic causes, and it is heavily nurse-driven.
Our first step is fluid management.
Right. We need adequate total intake, around 1,500 to 1,600 milliliters daily, taken in small, consistent increments throughout the day.
And this prevents urine from becoming highly concentrated, which is really irritating to the bladder.
And patients must strictly avoid known bladder irritants. caffeine, alcohol, carbonated drinks, and artificial sweeteners.
Next is establishing a standardized voiding frequency.
Right, we're trying to empty the bladder before the volume reaches the point of leakage.
And the techniques here include timed voiding,
Voiding by the clot.
prompted voiding, which is critical for cognitively impaired patients where staff initiate the voiding sequence, and then habit retraining and the formal bladder retraining or bladder drill, which involves using urge inhibition techniques to gradually lengthen the time between voids.
And the physical foundation of all this therapy is pelvic muscle exercises, or PME, or Kegels.
Kegel.
These strengthen the pelvic floor muscles used to stop the flow of urine or flatus.
So what's the technique?
The technique involves tightening these muscles for 5 to 10 seconds, followed by 10 seconds of rest, repeated 2 or 3 times a day for at least 6 weeks.
And the crucial clinical insight here is that biofeedback assistance dramatically improves a patient's ability to locate and correctly strengthen these muscles.
It really does. We also use adjuncts like weighted vaginal cones or electrical stimulation to help elicit a passive contraction and muscle re-education.
Pharmacologic therapy is secondary. For urge incontinence, we primarily use anticholinergic agents to inhibit those involuntary bladder contractions.
A newer option is mirabegron, a beta-3 adrenergic agonist. But we have to caution patients with hypertension as it can elevate their blood pressure.
Right. And for stress incontinence, agents like pseudoephedrine sulfate can increase outlet resistance.
But again, caution is mandatory for men with BPH or existing hypertension.
If conservative management fails, then we move to surgery.
Right. The options aim to either support or compress the urethra. Periurethral bulking, where collagen is injected into the urethral walls, is minimally invasive, but it does require periodic re-injection.
And for more severe sphincter issues,
we might see an artificial urinary sphincter implanted, which involves an inflatable cuff and a control pump, often placed in the scrotum for men, allowing the patient to manually control the closure.
As nurses, our management really prioritizes skin health. We have to routinely assess the skin to differentiate between incontinence-associated dermatitis, or IAD,
which is irritation and inflammation due to chronic moisture,
and a true pressure injury. They look similar, but they require distinct prevention and treatment protocols.
And research shows a significant gap in nurse knowledge regarding IAD prevention protocols, which really highlights why standardized education is so critical.
Promoting continence through education involves practical daily advice. Avoiding irritants, restricting diuretics after 4 p.m., quitting smoking to reduce coughing spasms, preventing constipation, and maintaining that regular voiding schedule.
5 to 8 times per day.
Okay, moving to the opposite problem, urinary retention.
The inability to completely empty the bladder.
Right, and chronic retention usually causes overflow incontinence.
A simple clinical benchmark is that middle-aged adults should have less than 50 milliliters of residual urine.
And for older adults?
For older adults, 50 to 100 milliliters may be normal due to decreased contractility.
The causes are legion: diabetes, prostatic enlargement,
The most common cause in men.
urethral pathology, trauma, or neurologic disorders, and certain medications that either inhibit the detrusor muscle or increase outlet resistance are common culprits we have to screen for.
When you're assessing for retention, you need to ask some key questions.
Like,
when was the last time you voided, and how much? Are you having frequent small voids or just dribbling? Do you feel pain or fullness in your lower abdomen?
and then we perform a physical assessment, checking for suprapubic dullness or tenderness on percussion, which indicates a distended bladder.
Nursing management focuses on promoting normal elimination and preventing overdistension. We start with behavioral techniques.
Privacy, ensuring a comfortable position sitting for women, standing for men.
Applying warmth, like a sitz bath or a warm compress, and using trigger techniques like running water or tapping lightly above the pubis.
If the patient still can't void, we need immediate intervention.
First, use a bladder scanner to quantify the residual volume.
And if that volume is high,
Typically over 300 milliliters, straight catheterization is also necessary to prevent long-term damage from overdistension.
and if a severe obstruction is present, like BPH, and urethral catheterization is difficult or impossible.
A urologist may need to insert a suprapubic catheter,
A critical concept is the neurogenic bladder.
which is dysfunction resulting from a nervous system disorder, spinal cord injury, multiple sclerosis, diabetes, or stroke.
Pathophysiologically, we divide this into two primary types based on where the nervous system lesion is. The first is the spastic or reflex bladder.
This results from a lesion above the voiding reflex arc an upper motor neuron lesion.
And the result is?
The patient loses conscious sensation and control, and the bladder empties involuntarily on reflex and often incompletely,
The second type is the flaccid bladder.
which is caused by a lower motor neuron lesion, often seen with trauma or diabetes. Here, the bladder fills and stretches dramatically, becoming severely distended.
And because the sensory pathways are damaged, the patient feels no urge or discomfort.
Correct, which results in overflow incontinence. And that lack of sensation means nurses must be hypervigilant for signs of severe, undetected hydronephrosis.
So the goals of medical management are standardized: prevent overdistension, empty the bladder completely and irregularly.
Maintain urine sterility to prevent kidney stones and ensure adequate bladder capacity without reflux.
Interventions focus on establishing a reliable emptying method.
That's right, continuous catheterization, intermittent catheterization, or self-catheterization.
Other management methods include maintaining a low-calcium diet to prevent calculi, increasing mobility, and ensuring a liberal fluid intake.
And for bladder retraining, we use time schedules. For flaccid bladders, we teach double voiding.
What's that?
It's voiding and relaxing and then attempting to void again 1 or 2 minutes later to help maximize emptying. Pharmacologically, parasympathetic meds like bethanechol may be used to increase detrusor muscle contraction.
So catheters are life-saving tools, but they remain a significant risk.
A very significant risk.
They're used for clear, necessary purposes: monitoring IO in critical patients, postoperative drainage, relieving retention or obstruction, and preventing urinary leakage in patients with severe, non-healing pressure injuries.
But the rule remains: only insert if it's absolutely necessary.
And if an indwelling catheter is required, we return to the imperative of CAUTI prevention.
The protocols are strict, recognizing that the risk increases 3% to 7% per day.
So we have to use strict aseptic technique for insertion, secure the catheter firmly to prevent movement, provide daily perineal care with soap and water, and maintain a completely closed system.
The never disconnect rule is vital, even for obtaining samples or for irrigation. And studies show using disposable wipes containing purified water, aloe, and vitamin E for perineal care can actually decrease CAUTI rates.
And the final, most important rule:
Discontinue the catheter the moment it is no longer medically required.
suprapubic catheters offer an alternative, inserted through a surgical incision above the pubis.
And the advantages are significant: potentially lower infection risk and improved patient mobility. They also allow patients to void sooner after surgery.
And how do you assess the patient's voiding ability with one of those?
The catheter is clamped for 4 hours, the patient attempts to void, and then the residual volume is measured. Removal usually occurs when the residual volume is consistently less than 100 milliliters on 2 separate checks.
We have to remember bladder retraining post-catheterization. If the detrusor muscle has been resting for an extended period, it loses its ability to contract effectively.
Right. So once the catheter is removed, immediate actions include placing the patient on a timed voiding schedule every 2 to 3 hours.
And we use the bladder scanner to check residual volume.
And if it exceeds 300 milliliter, a straight catheterization is done. Function returns when the residual volume stays below 100 milliliter consistently.
Finally, for impaired emptying outside the acute setting, intermittent self-catheterization, or ISE, using a clean technique is the gold standard for long-term care.
It promotes independence for patients with spinal cord injury or MSN. The schedule is typically every 4 to 6 hours during the day, plus before bedtime.
And we teach specific insertion steps. Women insert about 7.5 centimeters or 3 inches while in the Fowler position.
And men, holding the penis at a right angle, insert 15 to 25 centimeters or 6 to 10 inches.
We're going to pivot now to one of the most painful conditions in urology: kidney stones.
Urolithiasis or nephrolithiasis. They're common, and their incidence is rising, especially in women.
Stone formation occurs when the urine becomes supersaturated with substances like calcium oxalate, calcium phosphate, or uric acid.
And factors that favor this formation include chronic infection, urinary stasis, and prolonged immobility, which alters calcium metabolism.
Understanding the stone type is critical for prevention.
Absolutely. Calcium stones are the most prevalent.
Okay.
Uric acid stones are often seen in patients with gout or myeloproliferative disorders,
And then there are struvite stones.
which are complex and account for nearly 3/4 of stones in women. They form specifically in alkaline ammonia-rich urine, which results from urea-splitting bacteria like Proteus or Pseudomonas.
We also look at systemic causes, conditions causing hypercalcemia, like hyperparathyroidism or certain cancers, or excessive intake of vitamin D.
Manifestations depend entirely on where the stone is lodged and whether it causes obstruction or infection.
So stones located in the renal pelvis typically cause a deep, intense ache in the costovertebral region, accompanied by hematuria.
And if the pain suddenly becomes severe, with associated nausea and vomiting, that's what we define as renal colic.
When the stone moves into the ureter, the pain transforms into that classic, acute, wave-like, excruciating pain known as ureteral colic.
And this pain radiates down the thigh toward the genitalia. It's so severe because it's mediated by prostaglandin E, which increases ureteral contractility as the body tries to push the stone through.
And as a guide, stones that are 0.5 centimeter in diameter usually pass spontaneously.
Right, but anything over 1 centimeter typically requires some kind of intervention.
So the management goals are fourfold: eradicate the stone, relieve the pain, control infection, and prevent nephron destruction.
Immediate pain relief is paramount, often requiring opioid analgesics to manage that excruciating colic and prevent shock.
But here's a crucial point of synthesis. While opioids manage the pain, NSAIDs are highly effective
Why is that?
because they address the underlying mechanism. By inhibiting prostaglandin E, they reduce swelling and ureteral spasm, which physically facilitates the stone's passage, making them a cornerstone of modern treatment.
That's a great point, and hydration is the cornerstone of non-surgical management.
Absolutely. Patients must drink at least 8 to 10 8-ounce glasses of water daily, or receive IV fluids, aiming for a consistent urine output exceeding 2 liters per day.
This maximizes hydrostatic pressure behind the stone, which aids its passage.
Nutritional therapy has to be individualized based on the stone analysis.
Right. General advice includes limiting sodium to 3 to 4 grams daily and avoiding excessive protein intake.
What about for calcium stones?
If the stone is calcium-based, we usually don't recommend a low-calcium diet unless true absorptive hypercalciuria is confirmed due to the risk of osteoporosis.
And for uric acid stones?
A low purine diet is prescribed, which means avoiding foods like shellfish, organ meats, asparagus, and mushrooms. Allopurinol may be used to lower serum uric acid levels.
And oxalate stones?
We limit high oxalate foods like spinach, Swiss chard, chocolate, peanuts, and pecans.
If the stone won't pass, we move to interventions.
The first is ureteroscopy, which involves inserting a scope into the ureter to visualize the stone, then fragmenting and removing it, often using lasers. Temporary stents are frequently placed to maintain ureteral patency post-procedure.
And the most common non-invasive approach is extracorporeal shock wave lithotripsy, or ESWL.
Right. High-energy shock waves are delivered through the skin to fragment the stone into tiny sand-sized pieces that the patient then passes spontaneously.
And the key nursing action post-ESWL is to strain all urine to collect the fragments.
You also have to teach patients to expect hematuria for 4 to 5 days, and that bruising on the treated side is normal.
For very large stones, enderologic methods like percutaneous nephrolithotomy are required.
Right. A nephroscope is inserted directly into the kidney, and the stone is pulverized or extracted. This is more invasive, and complications include a higher risk of hemorrhage and infection.
And finally, chemolysis.
This involves infusing chemical solutions directly into the kidney, often via a nephrostomy tube, to dissolve specific stone types, usually struvite stones.
So for the nursing process, assessment focuses on the acute pain phase.
Right. We need to document the severity, location, and radiation of the pain, and check for associated symptoms like nausea, vomiting, or diarrhea.
And the non-negotiable step is to strain all urine for stones or gravel and send them to the lab for analysis, which guides long-term prevention.
And we also monitor for any concurrent UTI signs.
Interventions prioritize rapid pain relief. Prompt administration of opioid or NSAI analgesics is essential.
And we encourage position changes for comfort and ambulation, as movement can sometimes facilitate stone passage.
Complication management requires aggressive fluid management, ideally 3,000 to 4,000 milliliters per 24 hours. We track IO meticulously.
Here's a critical safety alert. A sudden severe increase in pain intensity must be reported immediately.
Why is that?
It often signals a ureteral obstruction by a stone fragment, which can rapidly cause irreversible kidney damage or sepsis.
So we also monitor vital signs closely for fever, indicating infection.
And home and transitional care focuses on prevention. High fluid intake is the absolute mainstay.
Patients must be taught to monitor their urinary pH if indicated and recognize symptoms of recurrence: new flank pain, fever, or persistent bloody urine.
And post-ESWL, we remind them to expect hematuria and monitor their temperature daily, reporting any fever above 38 degrees Celsius.
Okay, let's talk about trauma. Trauma to the GU system is predominantly blunt, about 85%.
Often resulting from high-impact events like motor vehicle accidents or falls, but penetrating injuries and surgical mishaps also contribute.
Ureteral trauma is typically the result of penetrating injuries or accidental injury during complex surgeries like gynecologic or urologic procedures.
And there are often no specific external signs.
Right. Surgical repair is required, frequently involving stents to ensure urine diversion away from the suture line while healing occurs.
Bladder trauma is closely associated with pelvic fractures or a sudden blow to a full lower abdomen.
And injuries can range from contusions to full rupture, which can be extraperitoneal or intraperitoneal.
The big risks are hemorrhage, shock, and sepsis from urine extravasating into the abdomen.
The most important point for assessment in trauma is recognizing the classic triad associated with urethral trauma.
Which is 5 times more common in men due to its anatomy.
The 3 signs are blood visible at the urinary meatus, the patient's inability to void, and a distended bladder. This triad demands immediate attention.
Management goals across all trauma types are clear. Control hemorrhage, manage pain and infection, and maintain drainage.
We monitor HCT and HGB for hemorrhage and watch for signs of oliguria or hypovolemic shock.
For urethral trauma, a suprapubic catheter is usually necessary to divert urine and maintain drainage. But this must only be inserted after a urethrogram confirms the extent of the injury to avoid further stricture risk.
Nursing management requires frequent, detailed assessment for flank or abdominal pain and swelling that might indicate internal bleeding or leakage.
And patient education focuses on incision care, fluid intake, promptly reporting any signs of decreasing kidney function, and restricting strenuous activity for about 1 month to prevent delayed complications or bleeding.
Now for urinary tract cancers, specifically cancer of the bladder.
It's the 6th most common cancer, and it hits men much more frequently than women, predominantly affecting older adults over the age of 65.
The single non-negotiable leading risk factor is tobacco use,
especially cigarette smoking. This has to be the first thing we assess.
Other significant risks include chronic occupational exposure to industrial chemicals found in processed paint, metal, and petroleum products, as well as genetic predispositions and previous pelvic radiation.
The clinical presentation is often insidious, which can lead to a delayed diagnosis.
And the most common critical sign that should prompt an investigation is visible, painless hematuria.
Right. Secondary symptoms can arise if an infection occurs, leading to frequency and urgency. Pelvic or back pain suggests that the cancer may have become invasive or metastasized.
Diagnosis is confirmed by a tissue biopsy, usually performed after imaging studies like cystography, urography, CT, or MRI.
The pathologist analyzes the tissue. We also use cytologic examination of the urine, which can detect shed transitional cell carcinomas.
Medical management depends heavily on the tumor's grade and stage.
So simple papillomas can often be treated with transurethral resection or fulguration.
But invasive or multifocal cancer requires a simple or radical cystectomy.
Removal of the bladder. This is a massive operation that necessitates creating a urinary diversion.
And a radical cystectomy is extensive. It involves removing the bladder plus surrounding reproductive organs.
Right, the prostate and seminal vesicles in men, or the uterus, ovaries, and vagina in women.
For less invasive or recurrent superficial tumors, we use pharmacologic or intravesical therapy.
The agents are delivered topically, directly into the bladder. The most effective and commonly used immunotherapeutic agent is BCG Live, a bacterium derived from Mycobacterium bovis.
And it has a proven advantage in preventing recurrence over chemotherapy.
It does. And the specific nursing action is ensuring the patient retains the solution in the bladder for 2 hours before voiding.
Radiation is typically reserved for preoperative shrinking or for inoperable tumors combined with chemotherapy.
This section covers the consequences of cystectomy. These procedures drastically change the patient's anatomy and lifestyle, making nursing education and support paramount.
And we have to clearly distinguish between the 2 main types, those requiring an external collecting system and those that are continent.
Let's start with the ileal conduit, or ileal loop.
This is the oldest and most common external diversion. It's conceptually simple.
The ureters are transplanted into an isolated 12-centimeter segment of the terminal ileum, which is then brought out through the abdominal wall as a stoma.
And urine drains continuously into an external bag. This is not a continent diversion.
The key advantages are its low complexity and complication rate, and the fact that it prevents nocturnal incontinence because it drains constantly.
But patients face risks like wound infection, ureteral obstruction, and a common electrolyte imbalance, hyperchloremic acidosis.
Right, and long-term, there is a risk of stoma stenosis.
Nursing management begins preoperatively. The WOC nurse, the wound ostomy continence nurse, is crucial here.
Absolutely. They mark the optimal stoma site. It has to be away from creases, scars, and the belt line, and it must be visible and reachable by the patient for self-care.
Post-operatively, we monitor urine volumes hourly. An output below 0.5 milliliters per kilogram per hour is a red flag for obstruction or dehydration.
And a critical taking point is that mucus mixed with urine is normal.
That's a big one.
Because the ilean segment is still intestinal tissue, it continues to secrete mucus, which can look alarming if the patient isn't prepared.
Stoma and skincare must be meticulous. We inspect the stoma frequently.
A healthy stoma should be pink or red and moist.
And any color change to purple, brown, or black indicates compromised vascular supply and must be reported immediately.
That stoma is ischemic.
We rely on properly fitted skin barriers and appliances because the alkaline urine will rapidly excoriate exposed skin.
For appliance management, the pouch must be watertight and emptied when it's 1/3 full to prevent leakage or the weight from pulling it off.
And odor control is a major patient concern.
It is. We advise avoiding strong-smelling foods like eggs or asparagus and using liquid deodorizers or diluted white vinegar inside the pouch.
And a crucial safety warning: patients must be taught never to use tape to patch a leaking pouch.
It must be replaced immediately to protect the skin barrier.
Now for the orthotopic neobladder reconstruction.
This is technically more challenging, and it aims for maximum anatomical and functional restoration. A new bladder is constructed from intestinal segments and attached directly to the urethra.
The primary advantage is the potential for near-natural voiding, which can lead to a higher quality of life than wearing an external bag.
But the patient profile must be very carefully screened.
So there are significant contraindications.
Yes. This procedure is unsuitable for patients with pre-existing renal or liver impairment, intestinal disease, or those who lack the motivation or cognitive capacity to adhere to a strict and difficult voiding regimen.
They have to accept the high risk of temporary or long-term incontinence, particularly nocturnal incontinence.
And why is that? It's because the intestinal segment lacks the natural sensory feedback and muscle stimulation of a native detrusor. Bladder retraining is absolutely mandatory.
The complications are high.
Fluid and electrolyte imbalances are common, especially metabolic acidosis, because the intestinal mucosa is permeable and absorbs urinary electrolytes.
And patients also face a higher risk of post-operative ileus around day 5.
Post-operative nursing management is complex. Patients typically have both indwelling urethral and suprapubic catheters.
And irrigation is often necessary.
Right. For example, 100 milliliters of normal saline every 6 to 8 hours is often necessary to flush out the excessive mucus secreted by the intestinal pouch and prevent blockage.
We also monitor electrolytes aggressively for acidosis and ensure high nutritional intake to support healing and prevent ileus.
Neobladder training begins once the pouch is deemed watertight. Patients must learn to void in a sitting position and use the Valsalva maneuver bearing down to empty the neobladder.
Because it lacks the strong contractility of a native bladder.
Exactly. They must also perform PMEs daily and adhere to a timed voiding schedule every 2 to 3 hours to achieve continence.
A third major category includes continent cutaneous diversions, such as the Indiana pouch.
This procedure uses segments of the ileum and cecum to create an internal reservoir that is accessed via a continent stoma on the skin.
So since this is a continent diversion, there is no external appliance.
Correct, but the patient must perform intermittent self-catheterization at regular intervals to drain the urine from the reservoir.
Postoperative care must be meticulous.
Very meticulous, often involving multiple tubes, ureteral stents, a cystectomy tube from the pouch, and drainage drains, all requiring careful monitoring and irrigation 2 to 3 times daily to prevent mucus from blocking the system.
Let's consolidate our discussion by focusing on the comprehensive care surrounding this major life-altering surgery.
Preoperative assessment has to be holistic. We evaluate cardiopulmonary status, as these are often older patients facing a long recovery. We assess nutritional status, which may be compromised by cancer.
But critically, we have to assess their learning needs. Dexterity, vision, mental status, and existing coping mechanisms for the impending change in body image and sexuality.
Our interventions really center on relieving immense anxiety. The fears are multi-layered: the cancer diagnosis, the loss of a major body part, the reality of the stoma, and the alteration of sexual function.
We have to provide emotional support and encourage the expression of fears. This is where recommending ostomy support societies for peer interaction is highly valuable.
And ensuring adequate nutrition is non-negotiable for wound healing.
Right. Patients receive a low-residue diet and preoperative antibiotic preparation to cleanse the bowel and minimize the risk of infection and ileus. Malnourished patients may require enteral or parenteral nutritional support.
And we cannot overstate the importance of stomach planning, always involving the WOC nurse.
The site has to be planned with the patient standing, sitting, and lying down, ensuring it is away from bony landmarks, scars, and belts, and most importantly, easily visible and reachable by the patient for independent self-care.
Postoperative management is focused on preventing complications in the immediate surgical phase. We monitor all drainage catheters and drains meticulously for patency in urine volume.
And a sudden decrease in output or increase in drainage must be reported immediately.
It could signal obstruction, leakage at an anastomosis, or potential hemorrhage.
GI function monitoring is key because we use the bowel. A nasogastric tube is often used for decompression until bowel sounds return, protecting the intestinal anastomosis.
And early ambulation is strongly encouraged to mitigate complications of immobility and promote GI recovery.
We prioritize maintaining skin integrity until the patient masters self-care. The system must be watertight to protect the peristomal skin from urine.
Liberal, scheduled analgesic administration, often via PCA or around-the-clock dosing, is crucial because comfort enables the patient to cough, deep breathe, and ambulate effectively.
And we have to actively monitor for major complications.
Like peritonitis, which is signaled by fever, abdominal rigidity, and pain, it indicates possible leakage at the intestinal anastomosis.
And stoma ischemia or necrosis.
This is due to compromised vascular supply, and it has to be recognized quickly. Any color change from the healthy pink to purple, brown, or black must be reported as an immediate surgical emergency.
Minor stomal retraction or separation is treated with careful application of protective pastes and powders.
Right. But if the retraction is severe, receding into the peritoneum, immediate surgery is required.
Promoting home care and self-esteem involves helping the patient achieve independence in ostomy management.
We encourage them to look at and touch the stoma early to foster acceptance. They need to know the normal characteristics: pincrid, moist, insensitive to pain, and that mucus is expected if the GI tract was used.
And for sexuality issues, we encourage open discussion with the patient and partner about altered function and exploring alternative expressions of intimacy.
And long-term, we must educate them on monitoring for delayed complications like vitamin B12 deficiency, especially if the terminal ileum was resected.
That was an essential and incredibly detailed review. We moved from the microscopic failure of the JEG layer and the physics of reflux that causes a simple UTI, all the way through to the massive anatomical changes and high-level nursing management required for an orthotopic neobladder creation.
The single unifying theme across all these disorders is the need for meticulous, individualized assessment, driven by an acute awareness of anatomy and function.
Absolutely. If you internalize one framework today, let it be the nursing process applied to these disorders. Knowing the pathophysiology is necessary, but the detailed interventions are what save kidney function and, frankly, save lives.
That's right.
Remember that early recognition of complications, from the sudden drop in urine output post-diversion to identifying the subtle confusion of urosepsis in an older patient, is your highest priority.
And never underestimate the power of conservative care. We saw that for avoiding dysfunction and incontinence behavioral therapies, the strategic use of keels and bladder training are the first-line defense. Advocating for the least invasive, most empowering option first is the definition of high-quality urologic care.
Thank you for joining us for this deep dive into the core concepts of urologic nursing management. Use these insights as the foundation for your clinical practice. Keep practicing that critical thinking, and we look forward to our next dive together.